welcome to the SmartEducation podcast, episode 12. This podcast is an ambitious project, an attempt to create added value to your daily practice. We invite national and international recognized scientists and clinical practitioners and give you the chance to spend some time with us while I pick their brain. So, today here we have with us Claire Robertson.
Thank you. Nice to be here.
AKA Claire Patella.
That's right.
May I introduce you shortly, Claire?
Sure.
Would that be okay? Well, Claire has worked in the NHS, academia and private practice and currently runs a specialist second opinion patellofemoral clinic at Wimbledon Clinics. Claire is also the physiotherapist for the Warren Smith Ski Academy, and she has lectured internationally and has many research papers and editorials published in internationally peer-reviewed journals. She's also a reviewer for several scientific journals, and Claire, she runs her own postgraduate courses on patellofemoral problems for physiotherapists. And we're very lucky to have you doing such one of those courses together here with us at SmartEducation.
Thank you. It's nice to be here.
So how are you doing?
Yes, really good. I've had a great day, good audience. So yes, it was good.
And did you enjoy your skiing last week in north of Italy?
Oh, actually, it was in France, luckily, yes.
So we were really lucky to have you, that you were not in quarantine due to the COVID-19 virus. No. Well, yesterday we started the day with telling everybody that the course would be a mixture of evidence, of clinical reasoning, and of course of your experience of seeing only patellofemoral patients for over 10 years now.
Yeah, it's about 12 years. So I've lost count. It's a lot of patelli.
Yeah. So it's great to have you once again, and it gives us the chance to ask you some questions. First of all, maybe I start off with the question. We've seen a lot of assessment tools today. You've seen, we've practiced a lot of them, and you use a very cool metaphor, I think, the shopping basket metaphor. Can you tell our listeners something about that?
Sure. Well, I think the problem with patellofemoral pain as a label is it's a big umbrella label, and you can get anything from an obese, hypermobile teenager through to a 45-year-old ultramarathon runner. And yes, they might both have that title of patellofemoral pain, but they're quite clearly totally different. So we need to have ways of which we can sort of knuckle down and explore in order to be able to give accurate treatment. And one way I like to think about it is it's always insidious onset pretty much. So what risk factors are in the shopping basket? So people might get away with a excessively pronating foot or an anteverted femoral neck in isolation. They might be in the shopping basket, but if that's all, they might be fine. Mm-hmm. But if other things come into the shopping basket, such as a female who's had a baby, she's deconditioned, she's put a bit of weight on, we've got a bit more alongside that femoral neck anteversion than previously. Mm-hmm. And that is what tips the balance. Mm-hmm. And I find that it's good conceptually for clinicians, because it gets you to reason through, and it's good for the patients. The patients like to understand why their pain is there. Mm-hmm.
Yeah, it's all about education. Once again, we've said it a lot of times here during the podcast. What about BMI as a risk factor?
Yeah, so BMI is a really interesting area of emerging literature around osteoarthritis. Mm-hmm. And the literature that's coming through quite clearly shows us that if you have someone that is overweight, and if you have someone that is having an increasing BMI over time, that they are more likely to have rapid degradation of their cartilage, bone marrow lesions, and synovitis, all the things that can lead to a painful osteoarthritic knee.
Mm-hmm. Mm-hmm. Well, since we're talking about patellofemoral pain, if I see those patients in my clinic, they often complain about crepitus. So we've talked about that today as well.
Absolutely.
And I know that in 2012, you were awarded a research grant by the Physiotherapy Research Foundation to investigate the meaning of crepitus to patients with patellofemoral pain syndrome. And I think also it may be interesting to share the results of that research and how it could help us educating our patients who have to deal with dead crepitus. And it's a question, like I said, I get a lot from patients. They have certain beliefs about this, mostly negative thoughts. What would we be saying to those patients to really help them?
Yeah, well, I think there's a number of things. I think, first of all, the research really confirmed my suspicions that patients are really alarmed by this. And the research really reveals very fear-avoidant behaviour. Mm-hmm. So it's really important for us to not take this topic lightly. And some of the patients also felt that it hadn't been taken seriously, despite actually being as much, if not more, of a bother to them than the pain. So the first thing is there's a really valuable question that I ask patients if they mention their crepitus.
What do you think it means?
Exactly. You were listening earlier.
Yeah, I was paying attention.
And it's just such a good question, because if they say, I don't know, I don't really think about it, that's fine, move on. But if they say things like, it means I have arthritis, or it means my knee is wearing away, it means I need to be careful, then without doubt, we need to take time to address that inaccurate health belief. And so, first of all, I manage expectation from session 1 in that I manage the expectation that the pain, I say the pain is the abnormality, and the pain we should aim to alter, but we want the crepitus, we might well see the crepitus remain, and separate pain and noise in your mind. So I manage that expectation, and then I take time to explain that the crepitus is either bubbles of gas popping, or it's the patella clunking, or sometimes it's what perhaps creates the most alarm. It's that fine grating. Patients often get it on the stairs, and that's a phenomenon where you get fluid moving through a slightly uneven surface. So if we view it as a normal finding to have some irregularity in the retropatellar cartilage, then when the fluid moves through that, we may well get some noise from it. And it's okay. It doesn't demonstrate level of degradation. It doesn't have any correlation with the rate at which the knee is going to change or deteriorate. And actually, further research has been done since my research, looking at this quantitatively, even looking at it with people with osteoarthritis, showing that it does not increase your odds of needing a knee replacement. But I think people skim over it as a topic. I think people don't, it's a funny topic, isn't it? Noisy knees. So people often don't take it seriously. And one patient said to me, I mention it to my GP, I mention it to my orthopedic surgeon, and I've mentioned it to physio, and they don't seem to take note. And it might not be important to them, but it's important to me. So it's worth taking the time out to talk about it.
I plead guilty also a little bit. Sometimes I say to them, just don't bother. It doesn't mean anything. And but on the other hand, they need some more explanation about it.
I think that's right.
I like the analogy that you did. Maybe you could elaborate on that as well.
With the carpet.
With the water on a flat surface, and if you put friction on it versus the water on a carpet.
So I say to patients, look, if I pour water on a flat table and swish it around, we won't get much noise. But if we pour it on a thick carpet, and I often use that opportunity to say the thick carpet's like your thick cartilage that is present in your knee. So I reinforce the fact that cartilage is there and it's fine. If I swish it around on the thick carpet, I'll get the sort of noise from the friction. And this is the same as what is going on in the knee. And it's really important and to decrease that alarm. And in fact, I had a really interesting situation recently where a patient came to see me and we had a big conversation about crepitus. And he didn't live nearby, so I referred him back to his physio. And then the physio phoned me and said, the patient's not come back. And I said, that's strange. Let me phone the patient. And I phoned the patient and he said, after our conversation about crepitus, I just decided to get on with life and not worry about it. And you know what? I'm fine.
Very good. Well, you also made, I think it was your leaflet, Why Are My Knees Noisy?
Yes, exactly. Yeah. So I did that in conjunction with Musculoskeletal Science and Practice.
Would that be something that you might give us the okay on to translate that to Dutch?
Yes, of course. Absolutely, because it's a really useful handout.
Yeah, we could use it for physiotherapists can use it in their waiting room for their patients. Yeah.
And it's another sign I'm taking it seriously. I'm taking it seriously now if I've got a leaflet here for you on it.
Mm-hmm. Okay, let's move on to fat pads.
Lovely.
Yeah. Quite often the fat pad or Hoffa's pad can be seen as a source of nociception in the anterior knee region. And I think it was on Twitter, on your Twitter account, you made a remark about fat pads. Your catchphrase with fat pads is, they're tricky, but not impossible.
Absolutely.
Yeah.
I see a lot of these patients. A lot of them have found me on the internet. And a lot of them are at the end as a tether with this problem. I think for a number of reasons. I think it's nasty pain. It's the one that has people in tears in my clinic, I would say, more than anything. It's very irritable. So often when people think they're getting better, then suddenly, boom, off it goes again. And I think the third thing that really upsets people is the fact that the worst two things for it generally are standing and walking, which is so difficult to eliminate because it's very much a problem that's aggravated with extension.
Well, an example of irritation of the fat pad is sometimes seen in arthroscopies.
Absolutely, because they have to go through the fat pad with the tools. Yeah. So definitely.
And one other thing in ACL rehab, you see, and it is important that physiotherapists try to go to the end range of extension in the presence of a puffy, painful fat pad. And how do you deal with that? What choices do you make? Because if you try to go full for the end range, you might irritate the fat pad at the same time without knowing that you're actually maybe.
I think it can be a real dilemma. I think it can be. And I think once they've got full, easy, passive extension, then we have to just say to the patient, right, we need to just check each day that you're not losing that or it's not tightening up, but don't keep hammering that fat pad because that's going to become a really big problem too. And then you won't be able to extend your knee because the fat pad is so sore. So it is absolutely a balance. And even in the ACL patients using fat pad offloading techniques, taping, so that you can work into extension without so much irritation to the fat pad, using some ice massage so that brings down the fat pad edema. So I think these things are really important.
Well, while treating that ACL patient, for example, and I know if you have those painful fluffy fat pads, it's better if you give them some time. And to unload it with some tape. But the dilemma is you don't have that much time going to full extension.
And I think that's right. If it's fairly early on with the ACL, you have to prioritize the extension.
Well, in your experience, how much time does a fat pad need to settle down?
Well, it depends whether it's trauma-driven or driven by their poor biomechanics. So if it's trauma-driven, actually, I find as soon as you tape them, ice them, if possible, minimize, should we say, the amount of extension work, then it will start to settle quite quickly. Within 2 weeks, you'll see quite a big difference. If it's more chronic because of, say, their lateralized tibial tuberosity means their lateral fat pad is getting impinged, it has often been going on for longer and it's more difficult to address those biomechanics. So then we're into months of treatment. Yeah.
For me, it was really difficult, Claire, to choose the topics that we were going to discuss because you mentioned a lot during the day. It was really interesting. Maybe a good question, because I have some questions from the participants as well to end off with, but maybe another question from my point of view. Since you run a second opinion patellofemoral clinic, where you spend, I think, an hour per patient, collaborating also closely with the treating clinician, what are the main reasons that you see those patients? I mean, what problems do they face and what went wrong during rehab initially? Yeah,
so it's a really good question. I think they're all patellofemoral or fat pad patients pretty much. I think, look, I certainly see the tricky end of the spectrum. There's no doubt about it. But I would say without doubt, the one thing that I see the most is patients having had too many exercises. And it's just exercise overwhelm. So if you've been given 5 or 6 exercises and then you've been told to do them several times a day, I mean, that's a huge ask when you really stop and think about it. And I much prefer like 2 or 3. If you really knuckle down the key issues and prioritize those, you can get it down to 2 or 3 exercises, good education, avoidance of aggravating factors, whatever that may be. And then over time, you can then build them up, change the exercises to make them harder. Don't add loads of exercises. Really, really keep the exercise program to an absolute minimum. And if it's strength-based, whether it's endurance or power, you can do it you should be doing it alternate days to fatigue anyway. So 2 or 3 exercises, alternate days, is much more likely to be done successfully than 5 or 6 exercises several times a day.
But then the trickiest thing is to choose the right exercise.
Well, that's what
that's why they
that's
come.
what I hope they get
that's
out
why
of my
they
course.
need to see and come and to do your course.
Yeah, and that's the whole point of the course, is to really try and give people the skills and the confidence that at the end of the day they're like, yeah, I'm absolutely just going to focus on calf length or gluteus medius in the frontal plane because I feel that's what they need.
Let's move on to some. Let's try to have some answers to the questions that participants sent me. One of them was, is there a place for electrostimulation while exercising?
Okay, so that's a good question. And actually, I've done some research on this. So we've done a lot of research, myself and an anatomist, on the architecture of the VMO. And we found that the fibre angle of the VMO changes as you get stronger, the angle gets bigger. And that's not a new concept. 1955 was the first paper on fibre angle. It's also called pronation angle. It's the same thing. So if we look at strength work, what we found is we did a study where we did closed kinetic chain exercises versus the same exercises with a muscle stim. And the group that had the muscle stim got the biggest muscle architecture change. So it was used as superimposition. So they did their exercises in time with the stim. So it wasn't a passive use of the stim. Okay.
A question that pops up multiple times. What about orthotics and reduction in the patellofemoral pain?
Yeah.
I know it's a big question,
but I
it's
think that
difficult to have a short answer.
Well, I think the short answer is yes, for some patients it's highly relevant and highly successful. First of all, ask them, are they different in different shoes and when they're padding around the house barefoot and socks, going up and down the stairs? And if they're categorically no different at all in any shape or form in different shoes or barefoot, I would question how relevant the foot biomechanics are. But if some of them can identify, oh yes, my pain is much better when I'm in this shoe or that shoe, then it's starting to give you the clue that maybe an orthotics is going to be useful. And then you need to be looking for that excessive pronation when you assess them.
But would you agree if I say that it's a good idea on the short term? And then maybe to give some more... to spend some more time on exercising after that the symptoms in the beginning are going away?
Yeah, well, if it's going to affect the pain and you're getting a short-term pain reduction, that's a useful thing because it means your exercise is going to be more effective. And then you can maybe look at strengthening the intrinsics of the foot or the whole limb alignment so that they don't have extra load down onto the medial border of their foot. But there are some patients who also, I don't want them to think that it's a quick fix and that's all they need to do. So again, it's patient selection, isn't it? If I don't want them to become passive in the process, I bung this in my shoe and it's fine.
Okay, I had another question, but maybe one last one. What about shockwave in treating for example, patella tendon, and what is your experience on that? Do you use it in your clinic, or do you?
We don't actually use it in the clinic. I've talked to some of the other sort of tendinopathy gurus about
Seth
this.
O'Neill,
Yeah,
for example.
exactly.
I know you are close friends with him.
Yeah. Seth came on my course actually. So he's Seth's great. And I personally think that shockwave is used better on other tendons than the patella tendon. So I do think generally with the patella tendon, with good rehab and removal of risk factors, you should be able to manage the tendinopathy.
Your husband He's an orthopedic surgeon, is he?
The cat's out the bag. Yeah, he's a knee surgeon.
He's a knee specialist.
Yeah, it's ridiculous.
And I wonder, what do you talk about during dinner then after work? Is it all about...
Patients ask this, and they're like, do you just talk about our knees? I'm like, well, we're quite sad, but maybe not that sad. So we do have a life beyond knees.
Yeah. And talking about your life, how difficult is it to keep balance as a working mom, patient, doing patients, giving lectures, doing research? And I'm sure a lot of our listeners are struggling with the same issues. Everybody's working hard, passionate about what they do. Do you have any suggestions? I know it's not about patellofemoral, but I
guess time management. I'm at like a military operation at home with my time management. I have to be. It's the only way that I can get everything done. So I'm really, really organized. And then I guess just prioritizing. So, and also, like with my academic reading, I always have stuff on me, always, that I can read. So if I'm waiting for a train, if I have my haircut, I'm always reading. I use all those funny little snapshots of time. That would be my top tip. Just always have stuff on you. You can read or listen to podcasts.
Podcasts.
There we go. You see? Yeah. You're driving to work, listen to the podcast. Yeah. Use that time wisely.
Yeah. I'll give you the chance to invite our listeners, if they want to know more about your work and what you do. I know you have something for them to how they can follow you.
Sure. So I've got my Twitter, which is Claire Patella, and my website, which is www.clairepatella.com, and the Claire's got an I in it. There's lots of resources for clinicians, but also for patients. And the patients have reported that they find the case studies helpful, and I guess that sense of I'm not on my own. There are other people out there with it. And then finally, I do my pick of the bunch, which I identify the best 3 papers as I see it in the field for clinicians every 3 months. And I send those references out. So if people are interested in that, they can just sign up for that for free on the website.
Okay, thank you very much, Claire.
Thank you. Thank you for having me.
Thank you. And I want to end off with inviting the listeners to follow us on our YouTube channel, to have a look on our podcasts, the other episodes, because I'm sure you'll find something in there that would be interesting for your practice. And be sure to watch out for us, because we'll be coming back with some more international speakers in the nearby future. So for now, all the best. See you soon.